Hello everyone, and welcome. I'm excited to kick off today's presentation on the high-risk approach. Today, we'll explore strategies and insights related to managing high-risk scenarios. We'll cover key concepts, best practices, and practical examples to give you a comprehensive understanding. Let's get started. Welcome to our discussion on the introduction to high-risk pregnancies. It's important to understand that while all pregnancies and deliveries carry some level of risk, there are specific categories where the risks are significantly increased. These are cases where either the mother, the fetus, or the neonate faces a greater chance of complications. In fact, about 20 to 30% of pregnancies fall into this high-risk category. Recognizing these cases is crucial if we want to improve overall obstetric outcomes. By identifying these women early, we can provide extra care and attention to help prevent adverse events. Even when we deliver adequate antenatal and intranatal care, this small high-risk group is responsible for a large proportion, around 70 to 80%, of perinatal mortality and morbidity. The risk factors for these pregnancies may be present before pregnancy, or they might develop during the course of pregnancy, labor, or postpartum. Interestingly, over half of maternal complications and around 60% of primary cesarean sections originate from this high-risk group. So, understanding and managing these high-risk pregnancies is key to improving maternal and neonatal health outcomes overall. Now, let's take a closer look at some high-risk cases during pregnancy, as outlined by the WHO. These are situations that require extra attention and careful management. First, we have elderly prima gravida, which refers to women who are pregnant for the first time at 30 years or older. This age group can have increased risks due to age-related factors. Next, there's the short-statured primi, meaning women who are pregnant for the first time and are 140 centimeters or less in height. Shorter stature can sometimes be associated with a higher risk of complications during pregnancy. We also need to be vigilant about threatened abortion and antepartum hemorrhage, or APH. These conditions involve bleeding or risk of miscarriage and can pose serious threats to both mother and baby if not managed promptly. Malpresentations are another concern. This includes any presentation of the baby that isn't the head-down position, which can complicate delivery. Preeclampsia and eclampsia are also classified as high risk. These are hypertensive disorders that can lead to severe complications if not properly controlled. Lastly, anemia remains a significant concern. It reduces the mother's ability to cope with the physical demands of pregnancy and can affect fetal development. Understanding these high-risk factors helps us identify women who need closer monitoring and tailored care to ensure the best possible outcomes for both mother and child. Let's take a look at some of the key factors that can influence pregnancy outcomes in different populations. First, we have elderly grand multiparas, which refers to women who are older and have had multiple previous pregnancies. These women may face increased risks during pregnancy, so it's important to monitor them closely. Next, we see issues like twins and hydramnios. Twins are naturally higher-risk pregnancies because of the increased load on the uterus, and hydramnios, or excess amniotic fluid, can lead to complications such as preterm labor or fetal distress. Moving on, a history of previous stillbirth, intrauterine device or IUD use, and manual removal of the placenta are all significant factors. These past experiences can influence current pregnancy management and outcomes, highlighting the importance of thorough medical history taking. Prolonged pregnancy, or postterm pregnancy, is another concern, as it can increase the risk of fetal distress and other complications. Women with a history of previous cesarean sections or instrumental deliveries also require careful monitoring, because they may have a higher chance of complications like uterine rupture or issues with labor progression. Additionally, pregnancies associated with medical diseases, such as hypertension or diabetes, demand special attention, as these conditions can affect both maternal and fetal health. Finally, we should consider the impact of treatments for infertility. While these interventions can help women conceive, they sometimes come with their own set of risks that need to be managed appropriately. All these factors are interconnected and underscore the importance of personalized care in obstetrics to optimize outcomes for both mother and baby. During labor, there are several complications that we need to be vigilant about. One of them is PROM, or premature rupture of membranes, which can increase the risk of infection and other issues. Prolonged labor is another concern. When labor lasts too long, it can put both the mother and baby at risk and may require intervention. Hand, feet, or cord prolapse is a serious situation where the umbilical cord slips out before the baby, which can cut off oxygen supply and needs immediate action. If the placenta is retained for more than half an hour after delivery, it can lead to heavy bleeding and complications. Postpartum hemorrhage, or PPH, is a significant concern because it's a leading cause of maternal mortality, so quick management is crucial. Lastly, puerperal fever and sepsis are infections that can occur after birth, and they highlight the importance of infection control and prompt treatment. These complications are all interconnected and emphasize why close monitoring during labor is essential for ensuring the safety of both mother and baby. Let's talk about screening high-risk cases. The key is to assess these cases early on, ideally during the first trimester of pregnancy. This initial assessment is crucial because it helps us identify potential risks right from the start. It can be done in a variety of settings, whether that's a large teaching hospital or a smaller community health center. It's important to remember that some risk factors might not be immediately apparent. They can emerge later on, so we need to keep an eye on the patient during subsequent visits. That means reassessing the risk as the pregnancy progresses, especially near term and again during labor. This ongoing screening process ensures we catch any new risk factors that might develop, allowing us to plan appropriately and provide the best care possible. Overall, early and continuous screening is vital in managing high-risk pregnancies effectively. Today, I want to talk about some important warning signs that every pregnant woman should be aware of. Recognizing these signs early can be crucial for the health of both mother and baby. First, if you have a fever higher than 38.5 degrees Celsius that lasts more than 24 hours, this could indicate an infection that needs medical attention promptly. Next, if you experience severe headaches or blurring of vision, don't ignore these symptoms. They might be signs of high blood pressure or other complications. Swelling is common during pregnancy, but generalized swelling of the body and puffiness of the face, especially if sudden or severe, should be checked out immediately. If you feel palpitations, or if you notice that you get easily tired or short of breath even when resting, these could be signs of heart or anemia issues that need assessment. Pain in the abdomen is another warning sign. Any persistent or severe abdominal pain should be evaluated to rule out problems like preterm labor or placental issues. Vaginal bleeding or watery discharge can be signs of infection, bleeding, or even early labor. It's important to report these symptoms right away. Lastly, reduced fetal movements are a sign that the baby might be in distress. If you notice fewer kicks or movements than usual, seek medical advice immediately. Remember, these warning signs are vital indicators that call for prompt medical attention. Always keep an open line of communication with your healthcare provider, and don't hesitate to reach out if you experience any of these symptoms. Let's talk about antepartum hemorrhage, or APH. This is when there's bleeding from or into the genital tract that happens after 22 weeks of pregnancy, when the pregnancy weight is over 500 grams, and before the baby is born. It's an important condition because it complicates about 3 to 5% of pregnancies, so it's not rare. What makes APH especially concerning is that it's a leading cause of both maternal and perinatal mortality worldwide. That means it can have serious consequences for both mother and baby if not managed properly. It's also worth noting that up to 1/5 of very preterm bobbies, so those born quite early are born in connection with APH. This highlights how unpredictable and potentially severe this condition can be. Most of the time, APH is unpredictable, which makes it challenging to anticipate and manage. Recognizing its significance helps us understand why close monitoring during pregnancy is so vital to improve outcomes for both mother and child. Let's go over some of the different terminologies used when discussing bleeding during pregnancy. First, we have spotting, which refers to staining, streaking, or blood spotting that you might notice on underwear or sanitary protection. It's usually light and can sometimes be mistaken for normal discharge, but it's important to pay attention to it. Next, there's minor hemorrhage. This is when the blood loss is less than 50 milliliters and has already settled. It typically doesn't cause significant symptoms, but it's still a sign that we need to monitor closely. Moving on, major hemorrhage involves blood loss of between 50 and 1,000 milliliters. Interestingly, even with this amount of blood loss, there may be no signs of clinical shock yet, but it's definitely a warning sign that something needs urgent attention. Then we have massive hemorrhage, which is when the blood loss exceeds 1,000 milliliters, or if there are signs of clinical shock. This situation is critical and requires immediate intervention to prevent severe complications. Lastly, recurrent APH refers to more than one episode of antepartum hemorrhage. This pattern suggests ongoing issues that need thorough investigation and management to protect both the mother and the baby. Understanding these different terms helps us communicate effectively and ensures timely, appropriate responses to each situation, keeping us aligned with the overall goal of safe pregnancy management. Today, let's discuss the etiology of antepartum hemorrhage. First, one major cause is placenta previa, which occurs when the placenta implants low in the uterus, covering or near the internal os, leading to bleeding as the cervix dilates. Next, we have abruptio placenta, or placental abruption, where the placenta separates prematurely from the uterine wall, causing significant bleeding and potential fetal distress. Another important cause is vasa previa, which involves fetal blood vessels crossing or running near the internal os, and these vessels can rupture during membrane rupture, leading to rapid blood loss. Excessive show, or heavy bloody mucus discharge, can sometimes be a sign of placental issues or impending bleeding. Local causes are also notable, such as bleeding originating from the cervix, vagina, or vulva, which may be due to trauma or infections. Lastly, there's indeterminate antepartum hemorrhage, where the source of bleeding isn't clearly identified, posing a diagnostic challenge. Understanding these causes helps us in early detection and management, ultimately improving outcomes for both mother and baby. Now let's talk about general management in this critical situation. First, we need to make a rapid evaluation of the woman's overall condition, which includes checking her vital signs, her pulse, blood pressure, temperature, and respiration. This quick assessment helps us understand her stability and guides our next steps. Next, it's essential to locate and assess the fetal heart rate. This gives us vital information about the baby's well-being and helps us determine if there's any immediate fetal distress that requires urgent action. We also need to assess the amount of blood loss. Excessive bleeding can indicate postpartum hemorrhage, and recognizing this early is crucial for timely intervention. Administering oxygen to the mother is a key step. This helps improve oxygenation for both her and the baby, especially if there's any compromise. Starting an IV line is another life-saving measure. It allows us to administer fluids or medications quickly if needed, which can be critical in stabilizing her condition. Importantly, we should not attempt any per-vaginal examination at this stage. This is to prevent any unnecessary risks or complications until we have a clearer understanding of her situation. Fixing a sterile pad over any bleeding site helps control blood loss and maintain cleanliness, reducing infection risk. It's also important to explain to the relatives what's happening. Clear communication helps manage their anxiety and keeps them informed about the steps we're taking. Finally, the mother must be referred immediately to the Family Resource Unit, or FRU, for specialized care. Prompt referral ensures she gets the expert intervention needed to manage her condition effectively. All these steps are interconnected. They form a comprehensive approach to stabilize the mother quickly and efficiently, aligning with our overall goal of safe and effective childbirth management. Hypertensive disorders of pregnancy are a significant concern, as they complicate about 10% of all pregnancies. That means roughly 1 in 10 pregnant women will experience some form of hypertension during their pregnancy. It's important to understand what we mean by hypertension in this context. We define it as a blood pressure reading of 140 over 90 millimeters of mercury or higher, and this has to be confirmed with 2 consecutive readings. These readings can occur at any point during pregnancy, so ongoing monitoring is essential. Recognizing and managing these disorders is crucial because they can impact both maternal and fetal health. Understanding the threshold helps us to identify at-risk pregnancies early and intervene appropriately to improve outcomes. This slide doesn't contain enough information. That's why we're moving to the next slide. Now, let's discuss some of the serious complications that can arise from hypertensive disorders of pregnancy. One significant maternal complication is HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. It's a severe form of preeclampsia that can lead to serious maternal health issues if not managed promptly. Another critical complication is acute respiratory distress syndrome, or ARDS, which affects the lungs and can cause severe breathing difficulties. Renal failure is also a concern, as high blood pressure can impair kidney function, potentially leading to long-term health problems. Pulmonary edema, which is fluid accumulation in the lungs, can occur due to the increased pressure and vascular changes associated with hypertension, making breathing even more challenging. Disseminated intravascular coagulation, or DIC, is another life-threatening condition where abnormal blood clotting occurs throughout the body, risking both bleeding and clotting complications. On the fetal side, hypertensive disorders can cause intrauterine growth restriction, or IUGR, where the fetus doesn't grow as expected, and intrauterine death, or IUD, which is a tragic outcome if the fetus cannot survive the compromised environment. Fetal distress is also common, often indicated by abnormal heart rates, signaling that the fetus is under stress. Prematurity is another concern because sometimes early delivery is necessary to save both mother and baby, but this introduces its own set of challenges for the newborn. Overall, these complications highlight the importance of early detection and management of hypertensive disorders during pregnancy to minimize risks for both mother and child. When it comes to management, the definitive treatment for this condition is delivery. However, it's crucial to wait until the lungs are fully mature and the pregnancy has reached a satisfactory gestational age before proceeding. This helps ensure the best possible outcome for both mother and baby. A key aspect of management is controlling hypertension. This involves assessing how severe the hypertension is, closely monitoring both the mother and the fetus's condition, and taking steps to prevent the onset of eclampsia, which can be life-threatening. When it comes to antihypertensive treatment, we typically start medication when blood pressure reaches around 90 to 100 mmHg, especially if the patient is being treated as an outpatient. The goal is to keep blood pressure under control without causing too much reduction, which could compromise placental blood flow. In addition to medication, proper rest and a high-protein diet are strongly recommended. These support overall health and help manage the condition more effectively. Overall, the management approach aims to stabilize the mother's condition, ensure fetal well-being, and plan for safe delivery once the timing is right. When managing preeclampsia, it's crucial to systematically monitor both the mother and the fetus. First, we need to measure and record the mother's blood pressure accurately. This helps us track any worsening or improvement of her condition. Next, testing the urine for protein and sugar is essential, as proteinuria is a key sign of preeclampsia, and sugar levels can indicate other issues like gestational diabetes. We also assess for generalized edema, which often appears as swelling in the hands, face, or legs, and can be a sign of worsening preeclampsia. Checking the fetal heart rate, or FHR, is vital to ensure the baby is doing well. Additionally, asking the mother about fetal movements, the frequency and pattern, is important because a decrease can indicate fetal distress. Finally, if the mother reaches 37 weeks of gestation, we need to admit her immediately. At this point, delivery becomes a key part of management, as the risks to both mother and baby increase significantly. All these steps are interconnected in our overall approach to ensuring the safety of both mother and child in preeclampsia management. Today, I'll be discussing the management of eclampsia, which involves 6 major steps that are crucial for ensuring the safety of both mother and baby. First, making sure that the woman can breathe is absolutely essential. We need to monitor her airway and respiration closely, because eclampsia can affect her breathing or lead to complications. Next, controlling the fits or seizures is vital. We often use anticonvulsant medications like magnesium sulfate to prevent recurrent seizures and protect the mother's brain. The third step is controlling the blood pressure. Hypertension in eclampsia can cause serious damage, so we carefully manage her BP with appropriate medications, aiming to keep it within a safe range. Fourth, we focus on fluid balance. Since fluid shifts and edema are common, we need to monitor and manage her fluid intake and output to prevent both overload and dehydration. The fifth step is delivering the baby. Sometimes, early delivery is the best option to resolve the eclampsia and prevent further complications, especially if the pregnancy is far enough along. Finally, providing comprehensive care after delivery is essential. This includes continued monitoring, managing blood pressure, preventing complications, and offering supportive care to ensure her recovery. All these steps are interconnected and vital parts of a holistic approach to managing eclampsia, which ultimately aims to protect both mother and child and ensure the best possible outcomes. Gestational diabetes, or GDM, is quite common, affecting about 18% of pregnancies. That's nearly 1 in 5 women, which really highlights its significance in maternal health. Women who develop GDM are at a higher risk of developing diabetes later on, especially type 2 diabetes. This connection underscores the importance of monitoring and managing GDM effectively. Treating GDM isn't just about the immediate pregnancy. It has long-term benefits as well. Proper management can reduce perinatal complications, meaning fewer issues for both the mother and the baby during and right after birth. Improving neonatal outcomes is a key goal here, ensuring healthier bobbies and safer deliveries. Overall, recognizing and addressing GDM is crucial not only for the health of the mother and baby during pregnancy, but also for their health in the future. It ties into the bigger picture of preventive care and improving maternal and child health outcomes. Let's talk about the screening of GDM, or gestational diabetes mellitus. Screening is a crucial step because it helps us identify women who might have elevated blood sugar levels during pregnancy. Early detection allows for timely intervention, which can significantly improve outcomes for both mother and baby. Typically, screening is done between the 24th and 28th weeks of pregnancy, although in high-risk cases, it might be done earlier. The most common method is the oral glucose tolerance test, or OGTT. This involves fasting overnight, then drinking a sugary solution, followed by blood tests at specific intervals to see how the body handles the glucose. It's important to understand that screening isn't just about diagnosing GDM. It's about preventing complications. Proper screening ensures that we can implement dietary changes, monitor blood sugar levels, and, if necessary, start medication to keep everything under control. Overall, effective screening is a key part of managing GDM, fitting into our broader goal of ensuring healthy pregnancies and healthy bobbies. Let's now turn our attention to the management of GDM. Managing gestational diabetes effectively is crucial for the health of both mother and baby. It involves a combination of lifestyle modifications and, when necessary, medical interventions. First, dietary management plays a central role. Adopting a balanced, carbohydrate-controlled diet helps regulate blood sugar levels. Regular physical activity also contributes significantly, improving insulin sensitivity. Monitoring blood glucose levels diligently allows us to track progress and make timely adjustments. In some cases, lifestyle changes alone might not be enough, and we may need to introduce insulin therapy or other medications. The key is individualized care, tailoring interventions to each patient's needs. Throughout this process, education and support are vital, empowering women to manage their condition confidently. Ultimately, the goal is to maintain blood sugar within target ranges, to minimize complications, and promote healthy outcomes for both mother and baby. Let's talk about anemia during pregnancy and the postpartum period. In India, the prevalence among pregnant women is quite high, about 58.7%. That means more than half of pregnant women are affected, which is a significant public health concern. Now, how do we define anemia in this context? It's when the hemoglobin level drops below 11 grams per deciliter, either during pregnancy or right after delivery. Anemia isn't all the same, though. It is categorized based on severity. Mild anemia is when hemoglobin is between 10 and 10.9 grams per deciliter. Moderate anemia falls between 7 and 9.9 grams, and severe anemia is when hemoglobin drops below 7 grams. Most cases of anemia during pregnancy are due to iron deficiency, making it the most common cause. This highlights the importance of addressing iron intake and deficiency management in maternal health programs. Understanding these distinctions helps us better target interventions and improve outcomes for both mother and baby, fitting into our overall goal of enhancing maternal health care. Now, let's delve into the complications that can arise due to anemia in pregnancy. On the maternal side, anemia can increase susceptibility to infections, which can further complicate the pregnancy. It also puts extra strain on the heart, potentially leading to cardiac failure. Additionally, anemia is associated with a higher risk of preterm labor, which is a significant concern for both mother and baby. Postpartum hemorrhage, or PPH, can become more likely because of poor clotting factors associated with anemia. Subinvolution of the uterus, which is delayed uterine contraction after delivery, is another possible complication. Anemia can also impair lactation, making it harder for mothers to breastfeed effectively. Furthermore, deep vein thrombosis, or DVT, becomes a concern because anemia can contribute to a hypercoagulable state. Moving to fetal complications, anemia in the mother can lead to intrauterine growth restriction, or IUGR, resulting in a smaller, growth-restricted fetus. It also increases the risk of anemia in the newborn and preterm birth, which are both linked to long-term health issues. Overall, anemia during pregnancy isn't just a simple blood count issue. It can impact both maternal and fetal health significantly. Recognizing these potential complications helps us understand the importance of early detection and management to improve outcomes for both mother and child. Now, let's talk about interventions to prevent and correct anemia. This is a critical aspect because addressing anemia effectively can have a significant impact on overall health and well-being. Preventive strategies often include improving dietary intake, ensuring adequate consumption of iron-rich foods, and promoting nutritional education. For those already affected, treatment might involve iron supplementation or addressing underlying causes such as infections or other health conditions. It's important to remember that a comprehensive approach, combining prevention with timely correction, is key to reducing the burden of anemia in populations. Connecting this to our overall theme, these interventions are essential steps toward improving health outcomes and building resilient communities. Now, let's discuss management strategies for anemia in pregnancy. For prophylaxis, the recommended approach is to give an IFA tablet, which contains 100 milligrams of elemental iron and 0.5 milligrams of folic acid, once daily for about 180 days or 6 months. It's important to start this after the first trimester to ensure fetal development is not compromised. When dealing with mild to moderate anemia, The treatment involves iron and folic acid tablets, specifically 100 milligrams of elemental iron plus 0.5 milligrams of folic acid, taken twice daily. This regimen should be continued throughout the postpartum period to replenish iron stores and support recovery. Regular monitoring is key, so HB levels should be checked monthly to assess response to treatment and adjust as needed. If the patient cannot tolerate oral iron or if compliance is an issue, parenteral iron preparations are an alternative option. In cases of moderate to severe anemia, the management becomes more comprehensive. Antihelminthic drugs, such as mebendazole 100 milligrams twice daily for 3 days or a single dose of albendazole 400 milligrams, are particularly important in areas endemic for hookworm, especially during the second or third trimesters, since hookworm infestation can significantly worsen anemia. Finally, for pregnant women with severe anemia, delivery planning is crucial. It should be scheduled carefully, ensuring that blood for transfusion is readily available to manage any complications that may arise during delivery. Overall, it is about a combination of prevention, regular monitoring, and targeted treatment to effectively manage anemia and improve outcomes for both mother and baby. Today, I want to talk about syphilis and the important steps being taken to address it. The government of India has made a significant policy decision to implement universal screening for all pregnant women. This is a crucial move to help identify and treat syphilis early, protecting both mother and child. Now, when we talk about pregnant women at high risk, we're referring to those who might be more vulnerable to infection. This includes women with a current or past history of sexually transmitted infections, or STI. It also covers women who have more than one sexual partner, as this increases the risk of exposure. Additionally, sex workers and injecting drug users are considered high-risk groups because of their higher likelihood of encountering and transmitting infections like syphilis. It's important to remember that signs and symptoms of syphilis can vary widely, depending on which stage of the infection the woman is in. These stages can range from early to late, and each presents different clinical features. Understanding these key points helps us see why universal screening is so vital. It enables early detection and treatment, ultimately reducing the transmission and impact of syphilis on mothers and their babies. This approach aligns with our overall goal of improving maternal and child health through proactive, comprehensive care. Let's take a closer look at the risks of syphilis in pregnancy. When a pregnant woman is infected, it can have serious implications for the fetus. For example, it can lead to low birth weight, which is often associated with a range of health challenges later on. It can also cause perinatal deaths, meaning the baby might not survive around the time of birth, or lead to congenital syphilis, where the infection is passed from mother to baby, resulting in long-term health issues. On the maternal side, syphilis can increase the risk of stillbirth, which is heartbreaking, and spontaneous abortions, where the pregnancy ends on its own early on. Additionally, it's important to remember that syphilis can complicate other conditions, such as HIV, making management more complex. Connecting this to our overall theme, these risks underscore the importance of early detection and treatment of syphilis during pregnancy. Addressing it promptly can significantly reduce these adverse outcomes and protect both mother and child. Let's talk about diagnosis. It's essential that all pregnant women are tested for syphilis right at their first antenatal care visit. This should be done using a point of care, or POC, test, which allows for quick and easy screening. If the facility has the capability to perform the rapid plasma reagent test, or RPR, then that can be used for testing as well. For women who are at high risk of having syphilis or those who have a history of adverse pregnancy outcomes, it's important to screen them again in the third trimester to catch any new infections that might have developed. Additionally, testing the spouse of a woman who tests positive for syphilis is crucial. It helps us identify potential sources of infection and prevent reinfection, ensuring both maternal and fetal health are protected. Overall, thorough and timely testing is a key step in breaking the cycle of infection and safeguarding the health of both mother and child. When it comes to treating maternal syphilis, penicillin remains the gold standard because of its proven effectiveness. However, it's important to remember that although severe allergies to penicillin are quite rare, we should always check the patient's history carefully. If a woman has a known allergy, we need to consider alternative options or take special precautions. Before administering penicillin, I always ensure to review her allergy history thoroughly. This step is crucial for patient safety. Additionally, since allergic reactions, especially anaphylaxis, although uncommon, can be serious, I make sure that emergency medications for managing anaphylaxis are readily available. Having these drugs prepared before giving the medication helps us respond promptly if an allergic reaction occurs. In summary, careful screening for allergies and preparedness for emergencies are key components of safe and effective treatment of maternal syphilis, aligning with our overall goal of protecting both mother and baby. Let's talk about hypothyroidism in pregnancy, which is surprisingly quite common in our population, with a prevalence ranging from about 4.8% to 12%. That means roughly 1 in 10 pregnant women could be affected, so it's definitely something we need to be aware of. Now, the risks associated with hypothyroidism during pregnancy are significant, both for the mother and the baby. For maternal risks, we see an increased chance of recurrent pregnancy loss and miscarriage, which can be deeply concerning for women trying to conceive. There's also a higher incidence of stillbirth, which underscores the importance of proper thyroid management during pregnancy. In addition, hypothyroidism increases the risk of preeclampsia, a condition characterized by high blood pressure that can pose serious health threats to both mother and baby. There's also a greater risk of abruptio placentae, where the placenta detaches prematurely, leading to complications in labor. On the fetal side, hypothyroidism can contribute to intrauterine growth restriction, or IUGR, meaning the baby may not grow as expected in the womb. It also raises the risk of preterm delivery, which can lead to additional health challenges for the newborn. Connecting all these points, it's clear that hypothyroidism isn't just a thyroid issue. It has profound implications for pregnancy outcomes. That's why early detection and proper management are key to improving both maternal and fetal health. Let's talk about screening for hypothyroidism and who should be considered for testing. It's particularly important for women living in areas with known moderate to severe iodine deficiency, as iodine is essential for thyroid function. Obesity is another factor that can be associated with thyroid issues, so it warrants attention. Women with a history of thyroid dysfunction or goiter should definitely be screened, since they're at higher risk of recurrence or ongoing problems. Family history is also important. If there's a history of mental retardation in the family or previous births affected by hypothyroidism, screening becomes crucial. Additionally, women with a history of recurrent miscarriage, stillbirth, preterm delivery, intrauterine death, or abruptio placentae are at increased risk, and screening can help identify underlying thyroid issues that might contribute to these complications. Lastly, women experiencing infertility should also be considered, since hypothyroidism can impact fertility. Overall, these points highlight the importance of targeted screening, especially when these risk factors are present, as early detection and treatment can make a significant difference in maternal and fetal outcomes. Now, let's look at the diagnostic criteria for thyroid function during pregnancy. As many of you know, TSH levels tend to be lower during pregnancy compared to when a woman is not pregnant. This is due to the increased demand for thyroid hormones and the influence of human chorionic gonadotropin, or HCG. Because of these changes, we have pregnancy-specific and trimester-specific reference ranges for TSH. In the first trimester, the normal TSH range is typically between 0.1 and 2.5 MIU per liter. Moving into the second trimester, it slightly shifts to about 0.2 to 3 MIU per liter. And in the third trimester, the range is generally around 0.3 to 3 MIU per liter. Understanding these ranges is crucial because they help us accurately interpret thyroid function in pregnant women. Now, when it comes to diagnosing subclinical hypothyroidism, or SCH, we define it as a serum TSH level between 2.5 and 10 MIU per liter, with a normal free T4 concentration. If a woman has a serum TSH above 10 MIU per liter, regardless of her free T4 levels, this indicates overt hypothyroidism, or OH. Alternatively, if the TSH is elevated but still below 10 MIU per liter, with a normal FT4, we're looking at subclinical hypothyroidism. These distinctions are important because they guide us in management and treatment decisions during pregnancy, ensuring both maternal and fetal health are protected. Now, let's discuss the management of hypothyroidism during pregnancy. The drug of choice here is levothyroxine sodium. It's important to take this medication on an empty stomach, ideally in the morning, to ensure optimal absorption. Once treatment is initiated, we need to monitor the patient's thyroid function closely. Specifically, TSH levels should be checked again after about 6 weeks from the start of therapy. This helps us assess whether the dosage is appropriate and allows us to make any necessary adjustments. Overall, effective management ensures healthy pregnancy outcomes for both mother and baby, highlighting the importance of proper medication timing and regular follow-up.